to ligate this to the medial canthus approach?
Actually, if we do the surgery carefully, know the landmark, usually injury is not common. Posterior artery is very uncommon as it is thick within the bone. It is very unusual to injury in the posterior artery. But anterior artery can be injured in some cases. In that case, in maximum cases, only packing is enough. Or if we can identify, cautery may be done. If it goes within the orbit, and how much bleeding occurs, it depends on that. And if it is peroperative case, we can see that there is swelling of the orbit, visual swelling of the orbit. In some cases, very progressive, rapidly progressing swelling may occur. In that case, we very simply we can manage it by removing the lamina papyracea, incising the periorbita, and in some cases maybe we have to remove some fats to remove the interorbital, to release interorbital pressure. Endoscopically and peroperatively. And endoscopically it is better and easier than the medial canthus approach. And because everything is in front of our eyes, in front of our vision, so we have not to go to by another way, doing another approach, doing another injury or incision in the medial canthal region. It is not practiced, I think, by the endoscopic surgeons. So that is the better way and easier way to approach, not by medial canthus approach. I don't know what is.
Totally agree with Bahur sir. So basically, how to ligate? Ligate, no way, not possible. If injured, if you want to ligate, then mid portion is the best, not laterally, not medially. And if any injury, then orbital decompression is the best. And we are ENT surgeon, not habituated to do the lateral canthotomy. Basically, I think medial canthotomy or lateral canthotomy.
Which you prefer, medial or
lateral canthotomy is the more preferable and easy way. So, but we are not doing regularly. If you want to involve the eye surgeon, then definitely lateral canthotomy. But we are the endoscopic surgeon, so for endoscopic surgeon, orbital decompression is the most easiest way. Simple.
If it is Dr. Chindabulla at the first postoperative care, how is it? Canthotomy or endoscopy?
So if the patient is still admitted in the hospital and you find that when you're doing round, the patient is swelling or the patient is coming down, then you have to suspect that there has been a bleed and it has been intraoperative. First thing that you need to do is you have to put some pressure on the eye and do a gentle massage, because you don't want to allow the blood to collect inside the orbit. You would rather push that blood outside into the nasal cavity.
How much long?
This is just until you can do a lateral canthotomy. Okay, so the easiest step to do is a lateral canthotomy, because if you're talking about a medial canthus approach, then this has to be done by a ophthalmologist. It is not something that we do, because you have to go a transconjunctival approach, and mind you that the vessel has actually already retracted into the periorbita. So when you do a transconjunctival approach, we actually land up outside the periorbita. That is, you are along the inside the lamina papyracea but outside the periorbita. So you're in that junction. If you look at it, like what sir was saying, is that it is easier to remove the lamina papyracea endoscopically for us. We can do it immediately rather than wait for an ophthalmologist to come and do it. So that doesn't give us any technical advantage over what we already have. But even the oculoplastic surgeons that I have worked with, they do not prefer to do a medial canthus approach when you have an anterethmoid bleed or a posterethmoid bleed, because you have to go intraconal. That means you have to cross the periorbita and go inside the orbit that is next to the medial rectus muscle, or even medial to the lateral to the medial rectus muscle, and you have to search for the vessel and then you have to ligate it. There is no genuine sense in doing that, because this is a very tiny branch of the internal carotid branch, which is the ophthalmic artery. Patient is not going to die because of it, but the problem is that the patient can lose vision. So if you can manage to reduce the intraocular pressure by any other method, then it is good enough. So you can do, if it is in the ward, you can do a lateral canthotomy first. because you will not have access to do a medial orbital decompression there. So put pressure gently and press and document that you have informed the ophthalmologist. Whether they come, don't come, or whether you need their help, don't need their help, that is secondary. But if the patient loses vision and this case goes to court, then the judge or the opposition lawyer is always going to question you, why did you not involve an ophthalmologist right from the beginning? And that amounts to criminal negligence on your part. So just document that you've informed the ophthalmologist and you would want their help. Okay. Then put pressure and put some massage. You can even give a tablet or a IV dose of acetazolamide because that will reduce the intraocular pressure, and inform the OT that you would like to shift the patient. This is if it is happening in the ward. And if you can do a lateral canthotomy in the ward itself, just give local infiltration in the upper and lower eyelid. Make with a 15 number plate, make a horizontal incision. When you lift with the forceps, you will see the inferior canthal tendon, snip it. That will give you about 15 mm of Hg of pressure release. Okay, so because the canthal tendon is released, the eyeball can actually come little more anteriorly. Now, beyond this, you cannot do anything in the ward. Okay, if still you are seeing that the pupillary reflex is sluggish, then you need to shift the patient to OT and do a medial orbital decompression. But only with the lateral canthotomy, if the pupillary reflex is becoming better, then you don't need to do anything further. Okay, but knowing me, I do not want to sit with the patient and check the pressure every hour or so. So I would rather just shift the patient to OT, do a medial orbital decompression and drain out all the blood. That is probably what I would do if I was having this problem in the ward. Now if you are having this problem in the OT, then there is no need to go and do a lateral canthotomy. You can straight away do a medial orbital decompression because you are already there, and cut the periorbital, release the blood, finish.
You said do the medial canthotomy or by the help of the ophthalmologist?
Lateral canthotomy?
Medial.
Medial canthotomy I don't do. Because I've never had to do it, to be very frank. I've never had to do it. I've had anterethmoid bleeds because we have tumors which go 360 degree around the anterethmoid artery. They would have eaten the whole of the skull base and they would be rotating encircling the anterethmoid 360 degrees. So when we remove, sometimes it does bleed and retract. But I've never had to do a medial canthotomy. I've done a lateral canthotomy on my.
Actually, medial canthotomy is of no use here, I think. And number one. And number two, when the patient is in the ward, post-operative ward or in the cabin, in that case, if pack is there, first of all, we have to remove the pack.
Okay, hope the questioner got the answer. Actually, medial canthotomy is not in our practice, it is done by ophthalmologist, but we can manage paravertebly easily with our experience and quickly. And if it is post-operative day, lateral canthotomy is easier for us. Our next question is how to identify and ligate the sphenoid penetrant artery. Dr. Shah?
Purab also mentioned during surgery, but my opinion to junior is very simple way. If you extend posterior, goes to the ostium, maxillary ostia, and go to the posteriorly, and just identify the inferior turbinate end and middle turbinate attachment, that portion just L separate or in ortho chanda ke just U separate, you just create the space and you will see the sphenopeteral artery.
I think Dr. Gaurav has shown beautifully how to identify the sphenopalatine artery. And I want to add something to Dr. Tushar's comment. That is, when we give the incision, as Gaurav has shown, and we elevate the mucosa or mucopericardium, in one place we will find the ethmoidal crest. That is very important landmark. And another thing is, when the artery comes, the flap will not be elevated. There will be some restriction. There is some restriction. Then that is the indication that I have reached the artery. And of course, the lacrimal crest is a very important landmark. Thank you.
Tomorrow there is the opportunity observe the carotid dissection, which will be performed by Gaurav from Sorority Medical College. Then we got the opportunity to clear our any kind of confusion.
Yeah, I'll demonstrate this. If you probably also remind me tomorrow, I will definitely show all the branches of the sphenopalatine artery, and also when we expose the pterygopalatine fossa, we will also see how from the IMAX, the through the pterygomaxillary fissure, the artery becomes the sphenopalatine artery, at what junction it becomes, and everything. We'll discuss this in detail. Actually, this is a very important procedure because, especially in summer, we get a lot of patients who have intractable epistaxis, and if their hemoglobin is dropping significantly in spite of us doing cautery or whatever along the little area, then this becomes a sort of a escalated procedure for those patients. So it's important we know this. I will discuss this surely, sir.
Actually, sphenoid artery is the main branch of the supply of the mucus of the nose, and it is the important cause of torrential epistaxis. So, as an ENT specialist,
Artery of epistaxis.
artery of epistaxis. So as an ENT specialist, we should have an idea to manage such kind of problem by ligation of the sphenoid artery. And everybody like to request to observe the cadaver dissection from tomorrow evening from Surabhi Medical College, which will be headed by the team of Professor Dr. Shahjahan Kobir. Our next question is gross question from a questioner: how to approach sphenoidal sinus? Babu sir.
Yes, there are three approaches to sphenoidal sinus. One is medial approach, one is median approach, and another is lateral approach. Median approach is transseptal approach, midline approach. Rhinologists usually don't follow this approach. And then is medial approach through the natural ostium. We know the landmark of the sphenoid sinus, and I mentioned in the morning that in one workshop I demonstrated endoscopic pituitary surgery, and some people are asking me why you don't sacrifice the posterior part of the middle turbinate. I told that we are the rhinologists, we usually don't like to sacrifice middle turbinate. We go directly to the sphenoidal ostium, punch around the ostium, we widen the ostium and go into the sphenoid sinus to identify the pituitary ciliatus. And another approach is lateral approach. That is the trans-ethmoidal approach. Usually we do it when we go for surgery for sinusitis or polyps like this. But during pituitary, we do usually medial approach, but median approach may be done as well.
Okay, this is a basic question.
All knows basically to open the sphenoid sinus. For junior, just one point I want to add. If transithmoid, definitely you know, but I always prefer for juniors, just identify the superior turbinate, just medial to the superior turbinate, just natural ostium is there, and just open the natural ostium and put the one just neuropathy and corroborate from the inframedial aspect of this transithmoid, and to open the otherwise there is a chance of injury if you are not so expert. So simple way for juniors, and learning curve is very less. Just open the natural ostium, then corroborate the towards through ethmoid. So it will be easy to, if scope is there, I will show how it is simple to open the sphenoid sinus.
In the next session, today and tomorrow, we got the opportunity to observe the live surgery by our expert panelist, and at the time we can got opportunity to clear our explanation regarding the confusion. Our next question is: what are the pre-operative preparation for a patient of endoscopic sinus surgery, and do you prefer any treatment before doing any CT scan, MRI? Tushar? The basic question.
Basic question, but sometimes some tricks is there. Always, if you treat the CT scan, always we do straight the CT scan. Sometimes my junior, sir, it is the simple case of maxillary internal polyp doing, but do endoscopy. And if you think that is the different way and different, sometimes fibrotic is there, then require definitely MRI. Sometimes MRI also required. Definitely during before phase we do routinely CT scan, but do endoscopy, not we treat the CT scan only. Do endoscopy, and if you think there is slight bit abnormality and some fibrotic, maybe angiography, maybe tumor, so at that case definitely you should do MRI also. Definitely Gaurav will ultimately.
Gaurav, what is the basic protocol in your center for the preparation of the patient before going to any endoscopy?
So if I see that the patient has got polyps on my endoscopy, I don't really bother to now do give the patient steroid and reduce it and then do a CT scan. I don't really bother to do that. The reason being that a lot of my patients, because I live in Bangalore and we have a huge IT based population. So if most of our patients have insurance. So if after giving steroids, if the disease is not there or not much, then the disease gets understaged and the insurance will not come through. So they will say you don't need surgery for this sort of case. But in reality, if you understand the pathology that is happening here, the polyps have gone, but this is only temporary. This patient has got an inherent inflammatory sinus disease. When you take him off steroids, or after about a month or two, these polyps are going to come back. So have you really done justice to the patient? No, not really. So if you want to identify, if you have got a really bad sinus where you're not able to understand the anatomy at all and you want to shrink the polyps and into the scan, just for the sake of understanding anatomy better, then definitely you can prepare the patient. But I, as a rule, now I don't give steroids for two reasons. One is, I don't want to understate the disease. Second thing is, I do a biopsy intraoperatively of the polyp because I want to strategize as to what is going to be the prognosis of this patient. If the patient has got high number of eosinophils per high power field, which is usually more than 10 per high power field, then the patient has got a poor prognosis in terms of recurrence. So this is how I strategize, prognosticate my patient. So I don't give steroids now anymore before preparing or whatever. But after doing the scan, if I see that the patient has got significant osteitis and a lot of disease, then yeah, I will give the patient some amount of steroids to reduce intraoperative bleeding. But having said that, today's case also you saw that there was so much osteitis on the scan, but we did not have troublesome bleeding. It was not like, okay, I'm going to stop here and I'm going to stop the case. That is not the amount of bleeding that I had today. So you can actually, if you can use some intraoperative tricks, you can still manage and go ahead even without steroid. I would say.
Very smart answer by Gaurav. Protocol is not only depends on the patient, also depend by the insurance policy.
Thank you for your nice session, other. But I think for the students and other, you should prepare the patient. You should give the steroid for the course, and no need of your income tax or other. And you should go for at least one CT scan. Otherwise, you are expert. Without seeing, you can be. But patient should be prepared. Thank you, sir.
Thank you, sir.
We know that if you shrink the polyp by using pre-op steroid, either topical or systemic, is there any chance of reducing bleeding during the surgery? Especially in case of recurrent cases where there is too much fibroid, there is a chance of more bleeding. If you use pre-op steroid, either topical and systemic, the polyp decreases, then I think the chance of bleeding is less. Do you agree with me or not?
Actually, Professor Chaudhary sir and Professor already said, it is our practice to prepare the patient for visualization, proper visualization, and actually for control the bleeding and for the beginner and basic surgeon. In advanced surgeon, it is possible for you, but in our practice, we always prepare the patient.
যদি insurance covers, we will have to do the same practice like you. No insurance covers.
You would agree with your senior officers? Now, you have a special protocol for your patient.
Sometimes I actually practice sometimes if there is minimum polyposis but symptoms of allergic rhinitis there. During endoscopy, I see some minimal polyps there. I usually give conservative treatment for a long time, at least 6 weeks before doing CT scan. And in some of the cases of early polyposis, we see the significant reduction of the polyps there. So in that case, we can continue the conservative treatment. And by this way, we can avoid some number of surgeries.
Yes, in case of early polyposis, especially in point level and middle terminal, early polyposis, there is a chance of significant control of the disease if you give steroid. Steroid and long-term antihistamine is written in the book and literature as well.
It is
long-term antihistamine.
it is important, already explained by Babur sir. Conservative treatment not only essential for people of the patient, and also it is practicing before imaging also. It is also important.
খুবই ব্যাপারে এটা জিজ্ঞেস করতে চাচ্ছিলাম যে আপনি এর সাথে কি কোনো অ্যান্টিফাঙ্গাল ইউজ করেন কিনা?
There is a sticky secretion, and clinically, if you think that there is maybe fungal polyposis or there is
Fungal mucin.
polyposis, fungal mucin. If you clinically suspect that, you can try antifungal as well, systemic antifungal. But not routine. It is used on clinical basis.
Okay. Our next question is, when we will do functional school sinus surgery in case of rhinosinusitis with the polyposis? And Dr. Gaurav, you practice when you
We do get a lot of cases. So if the patient actually qualifies for the definition of chronic rhinosinusitis, like if the patient has had the problem for more than a year, and if the SNOT 22 score is more than 44, then yeah, we would take the patient up for surgery. Because if a score of more than 44 means the patient has got a moderate to severe disease. Whether you find polyps or don't find polyps, the patient has some amount of inflammation. It could even be bacterial also. Or the patient might be having a biofilm inside of the sinus which is not able to reach with a douche. So what here, the role of medical management becomes more important than if you have polyps. So polyps is a genetic disorder. So there is some level of inherent mucosal inflammation.
without polyp, when you interfere the rhinosinusitis?
When we would operate. Yeah, like I said, if the patient has had the problem for more than a year and if the SNOT 22 is more than 44, that clearly indicates that the patient is not going to improve. And if the patient has taken clarithromycin for about 15 to 20 days or 3 weeks, then I think if he has failed all of this,
Recurrent acute attack.
acute attack I would not want to operate. Acute attack is something.
Recurrent.
Yeah, that is called as recurrent acute rhinosinusitis. That is a different entity. So what is the? I'll just clarify one point. What is the difference between RARS, that is recurrent acute rhinosinusitis, and CRS, that is chronic rhinosinusitis? In recurrent acute rhinosinusitis, what happens is that in between two episodes, the patient's symptom score will come down to 0. So if this is happening, then it is a case of RARS. So in RARS, there is no role for extensive surgery. You might want to do whatever is the trigger, like there might be a concha bullosa blocking the maxillary ostium, or there might be a cross septal spur which is blocking the ostium. That thing you can correct and then come out. That's pretty much what you're required to do. But in a patient who's got chronic rhinosinusitis, where the symptoms don't come down to 0 between two episodes, then there is role for extensive surgery like a full house fess or an anterior fess or whatever we would like to call it. That becomes an indication.
Thank you. There is a last question. If a patient of bilateral equator polyp involving medial aspect of the middle turbinate with confluence of anosmia, what should be the position of the middle turbinate after removal of polyp? I mean, what should I do? Medialization of middle turbinate or laterals of the middle turbinate? Polyp is situated at the middle of the middle turbinate bilaterally and with anosmia. After polypectomy, what is the position of the middle turbinate? Is lateralized or medialized? Gaurav?
I would always like to leave it medialized. So the anosmia is not because of the position of the middle turbinate, it's because of the fact that there is inflammation in the olfactory recess. In fact, almost every case that I do, I actually put a middle turbinate suture to actually widen that the sinonasal corridor. We have to understand one thing, that the whole surgery is being done because you want to have a widely open sinus corridor. if you actually lateralize the middle turbinate after doing it, then the whole purpose of surgery itself gets defeated. Because you are closing off the sinonasal corridor, and when the patient washes with steroid, it's not going to go inside the sinus. So I usually put a stitch between the middle turbinate and septum, go through the opposite middle turbinate, and I stitch the two middle turbinates medially. I always do a SNOT 22 before and after surgery in all my patients, and actually the SNOT 22 gets sent. I have a software where we send the SNOT 22 every couple of months, and we get the values and we get a graph also. I have not had a patient complain of anosmia because I have medialized the middle turbinate in any of our cases actually. We have data to prove this also. So the smell receptors are actually quite good, and whatever chemicals which are going in, they are microscopic. So I don't think unless you have created complete cicatrization of the middle turbinate with the septum. So there is a technique which is called as Bolgerization. I don't like that technique personally because you are creating raw surface area in the olfactory recess. So that is not a healthy thing to do because you are damaging the olfactory receptors there. Rather, you leave the two mucosal surfaces intact and put a stitch. That is a much better way of medializing the middle turbinate.
There experience that there was
Between middle turbinate and lateral wall? Yeah, we've had, especially when we are doing tumor surgeries and we have to drill extensive amounts of bone, you can have, but it's not a very big deal. When the patient comes back for follow-up, you just release it.
Okay.
Actually, the endoscopic picture we see, there is a concabulosa, and for concabulosa we remove the lateral segment, lateral lamina of that concha, because we have to give air space in the osteometal complex, and if polyp is, whether polyp is in the medial to the middle turbinate or lateral to the middle turbinate, the aim is to remove the polyp. Actually, if olfaction, hyposmia or anosmia occurs due to polyposis, we have to remove the polyp. It is not the factor whether the middle turbinate is laterally placed or medially placed. But in practice, we usually, as Gaurav said, we place it medially and we give our back or splint lateral to the middle turbinate.
Just one point. Definitely, we prefer main failure of the face surgery is the lateralization of the middle turbinate. So we want to medialize the middle turbinate. That is the main. But vulgarization, yes, you may do the vulgarization. Stitching sometimes difficult. Lower part of the middle turbinate, if you attach, then air will be there. As mentioned, the cicatrization. When all full middle turbinate will be adhesive type, there is a problem. Otherwise, lower part, if you attach with the septum, there is no problem at all. If you vulgarize the lower part of the middle turbinate.
You can spleen, and what is the position of the spleen? There is another question. Every one of the polyp tissue, we plan to keep spleen. What should be the location of spleen? Is lateral to the middle turbinate or?
Now, this is the silastic seat. If you definitely lateral, and also the one stent is there. Smith and Nephew, one stent is there. That is also fantastic. If you put that area osteometal complex area, then it will maintain the middle turbinate position. And also stent, but there is the I think it is the too tough silastic one stent is there I am using. That is also very smooth and good. Yes, and also place the proper position.
Another question recurrence of the polyp. During follow-up of the endoscopy after endoscopy surgery in important polyp, if we found early recurrence of polyp, what we our plan of how we manage the recurrence?
In this case, if you have already done a proper full house fest, that is all the bone work is complete, and this is only a soft tissue swelling, then you don't have to worry. You have three options. One is you can either give the patient some oral steroids, this will disappear on its own. Second thing is either you can just excise this polyp and take it out. It's just put some 10% local anesthetic spray, and you can just do this in the OPD itself. Third option is you can just take 1 ampule of dexamethasone and inject it into this polyp. So these are the three options that you have. When you inject it, it will just regress on
How much
its own.
times?
Sorry?
How much times?
Injection, just 1 or 2 sittings, that's more than sufficient. One sitting is actually enough. It will completely regress. If you inject it into the polyp, it will regress.
Actually, what is the routine protocol post-operative follow-up the patient?
So the first time that I see the patient after surgery will be after 1 week. The reason that I see them after 1 week is that even though they are doing the douching, in my hospital what happens is patient starts douching the same day of surgery. Like morning if I have operated, evening they start doing the douching. So that way what happens is you are not allowing a lot of clots or mucus to get collected. Because once it gets collected, it becomes hard. And when it becomes hard, it becomes more difficult for them to clear it out.
So you don't use pack actually.
I don't use pack.
So douching started from the beginning.
Day one I start douching. So you saw the surgery which we did. We didn't have any bleeding there. Why do you want to pack a patient? Because when you pack a patient, there is evidence now. There has been meta-analysis also which has proven that it causes pulmonary hypertension for the patient. That will make him bleed more when you remove the pack. So you can be honest and just recollect when you have removed the pack. I'm very sure that most of us would have experienced bleeding. It is just mental satisfaction that okay, well, I'll go home and I'll sleep comfortably. Nothing of that sort happens. It's all bullshit. Because when you remove the pack the next day, he will bleed. Because all that piled up blood will definitely come out. And let me tell you, especially if you are operating on a patient who is CRS without polyps and he's got bad bacterial infection, you don't want to pack. The basic of general surgery is that when you have an abscess, are you going to pack it? If you're packing, you will put a betadine pack. But otherwise, you would want to leave it open. You want it to drain. You want air to go in and sanitize that space. So at least I wouldn't want to pack. Even in skull-based surgery, I don't pack. After doing a JNA, I don't pack now.
In case of recurrent polyposis, there is no chance definitely in comparison with fresh case. In that case, do we avoid any packing?
So, if you observe, sir, today's case, if you have removed all this osteotic bone, then the chance of you having bleeding itself will come down. If you leave behind osteotic bone, that will bleed. Why? Because inside of the bone we have these Haversian canals. So that bleeding will not stop. So the bony Haversian canals, what was the whole fund of using the drill today was, when you drill out that bone, you are closing off all those Haversian canals. So you are not going to have bleeding to begin with. If you want, we can try this out. I'm here tomorrow also. We will not pack today's case. And we'll see what happens tomorrow. Only thing is, you will have mucosal bleed. If there is no compromise for you leaving an open artery and saying I'm going to pack and come out, because tomorrow when you remove the pack, that artery is going to bleed again. So you have to make sure that you've got good hemostasis and not pack the patient. That's pretty much it. There's been probably only one case in my life when I packed. That is because the patient had very bad hypertension which was not coming under control. So that is the only case where I have packed. Otherwise I have not packed so far.
I agree totally with Gaurav. We also follow if only polyp, but sometimes we routine, doing the septoplasty with polyp, doing the tartroplasty with polyp, then pack required. And our hospital protocol is that after 2 days the removal of pack and douching started, if pack is there.
What is the posterior nasal douching actually? It is important for
It's very important. The Namaz position is the best position, but it's not possible, every time. So my explanation to the patient, just target towards eye, this is, and just bend and try to. But otherwise, if you want proper douching, the Namaz position is the best way. But Namaz position is very difficult for me also, no. So
the preparation of
preparation is now the mixed preparation is available in India. Sodium bicarbonate, and you mentioned that was the boric, but I don't know the boric acid available. Maybe, but in our India nowadays, a lot of preparation is ready with nasal douching powder is available with sodium bicarbonate.
What is the
we usually practice only normal saline douching. I think that is sufficient, that is enough, not to make it complicated. But somebody practices somebody practices adding steroid, adding antibiotic like Neobacrine, Nebanol ointment like this. I find that normal saline douching is if properly done,
How many days continue?
at least 1 month. At least 1 month.
And legally steroid use?
Yeah, budesonide use basically 2 cc normal, 200 cc normal saline and with one rescue budesonide. And if you continue, if my patients continue, if allergic complaint is there, otherwise sometimes problem after 1 month is not sufficient. Some patients it may continue 6 months, 1 year. When disease progresses subside up to this, maybe we continue to prevent the recurrence of the polyposis.
Tushar,
Actually,
after finishing surgery,
Sir.
how many days after surgery you start topical steroids? অপারেশন শেষ করার অপারেশনের পরে কতদিন পরে ইউ স্টার্ট টপিক্যাল স্টেরয়েড?
On the
Basically,
day
after bag removal, on third day, one intranasal corticosteroid started. Spray was using everything.
We start 3 to 4 weeks after surgery, after healing. I think if you use immediately after surgery, I think healing may be delayed.
Not immunity, but in case of polyposis, there is the another surgery. So different protocol, different allergic, different system.
So for me, spray I don't use a lot, especially after surgery. The reason being, see, whatever practice that I'm doing, it's all evidence based, unfortunately, because I have to actually write, as per NABH guidelines, we have to have SOPs, that is standard operating procedures, and these SOPs have to be backed by evidence. The problem with the spray is that it can only go in one direction. You cannot expect a spray to curve or, so you have maxillary sinuses are on this side. So when you're spraying in the nasal cavity, it will not reach the maxillary sinus. Frontal sinus is here. It cannot bend and go like this. That is the reason why we use 70-degree scope, curved, punch, curved, debrider, all these things. Because, so if you look at it, and this is not just logic, they have actually done studies where they've used nasal spray, they put a tie with the spray, and they've actually in a cadaver sprayed and checked what is the deposition. The problem with the spray is that 90% of the drug gets deposited in the anterior part of the nose, even anterior to the middle turbinate. 90% drug deposition happens here. That is the space where you don't need any nasal spray to get deposited. So what are you doing? You are allowing bleeding to happen, because with that spray you are causing mucosal atrophy. When you cause mucosal atrophy in the littles area, the blood vessels will become more superficial, and whenever the patient has raised blood pressure or dryness in that area, it's going to bleed. So you are not really doing any benefit to the patient by giving the patient nasal spray. The whole point of us doing surgery was that you make the patient douche. The other problem with the nasal spray is that spray can only reduce inflammation. It cannot clear out debris for you. Okay. Now a patient who's got allergic rhinitis like this patient, you want to flush out that thick mucus that he had. You want to flush out all the dust, pollen, dog hair, cat hair, or ragweed, pollen, whatever he had, you want to flush it out, because that is what is instigating your reaction. So one is spray cannot bend and go inside the sinus. 2, it cannot remove all these debris that is there. So I would always prefer to do a sinus rinsing rather than do only a spray. When do I reserve spray for? So the first 15-20 days of after surgery, my patient is on a rigorous washing spree. Literally 2 times a day they have to wash, and 2 times a day they do head low position wash also. Sorry?
Antihistamine?
No, I don't prescribe long-term antihistamines, because there is absolutely no benefit of giving it. Because if a patient is getting surgery done, he's already in phase 2 of the allergic reaction. Antihistamine is not going to benefit. But when do I give antihistamine? I do give antihistamine, but it's not for 6 months. The plan of giving antihistamine is, suppose, let us say he's got pollen allergy. And in the pollen season, which is now, in summer, that is when the trees are all blooming, there's going to be a lot of pollen in the environment. That time I can put him on prophylactic antihistamine, because you don't want the reaction to happen itself. But that doesn't mean he's going to stop washing. What happens with time, after about 3 weeks of doing twice a day washing, I drop it to once a day, then I make it once in 2 days. Then it depends on the pathology of the patient. Like if the eosinophil count in the histopathology of the polyp is extremely high, like 50, 60, 100 cells per high per feet, then you know for a fact that this patient's tissue is infiltrated with so many eosinophils that even small amount of dust or pollen will trigger the reaction. So his washing has to be much more than if you take a patient who's got 5 eosinophils. You know that he's not going to have such a bad reaction, so he can wash maybe once a week. So the prognostication, that is why taking the biopsy is so important. That is why I don't give steroids before surgery, because I want a good biopsy. If the problem is genetic, he has to continue for a lifetime. Probiotic, I would agree, there is a very, very big role of probiotic. But
any immunotherapy, any flu shot.
Yes, I
Because
agree. So these things
routinely, yearly they should use the flu shot.
Absolutely.
They use the probiotic.
Absolutely. These are things which I would agree with. But see, when you are giving an antihistamine, you want to give for 6 months or even for a lifetime, if you are considering giving antihistamine, are you really doing justice to the patient? Because if the patient has got other issues, like for example urticaria, or if he's got asthma, then you don't have a choice. You have to give.
In India, there is a combined drug, both the montelukast and antihistamine.
Yeah,
and
we
some
have.
of you are prescribing the years together. It's a combined drug.
So I don't give montelukast so often. So the clear-cut indication when you want to give montelukast is if the patient has got lung involvement. In the upper airway, montelukast will not do a lot of benefit to you. It can at the most reduce minimal amount of inflammation, but the receptors, leukotriene receptors, are maximally located in the lower airway, not in the upper airway. So if you are putting montelukast with antihistamine for an upper airway issue, then you are not doing justice to the patient. And now montelukast, there has been evidence that it causes psychological disturbance also. That is a black label warning by the FDA. So I wouldn't want to definitely prescribe montelukast unless the patient has got lower airway involvement, and that has to come from a pulmonologist. So in my hospital, I have a pulmonologist just sitting next to my office. So if the patient requires montelukast, I would definitely tell the pulmonologist to prescribe it. I don't want to be involved if the patient develops depression, suicidal tendency. I don't want to be the one.
Chinese are even using the spring water nasal spray routinely. They have done for nasal douching and clearing.
Yeah.
Every day before sleep, spring water.
So I have read that
and
paper.
steam inhalation,
Yeah.
bedtime.
Steam inhalation somehow, so there has not been any evidence to prove that steam inhalation works. In fact, they have found that it can be counterproductive. So let us imagine that you have an injury on your knee and it's already inflamed. Are you going to put more steam on it to make it worse? You're not going to do that. Steam inhalation, in fact, if the temperature is very high, it can kill the microflora inside of your sinus. The whole idea of spring water, I agree with that. Why? Because spring water contains a lot of healthy bacteria. So that is the reason why they want you to do spring water douching. Probiotics, again, now there is evidence that if you take probiotics for 3 months, then the IgE value in your blood will actually come down. The inflammatory process in your sinuses will come down. There is proper evidence. In fact, this was my thesis research. We even did a study on this where we did a probiotic. We took 2 separate Petri dishes. We harvested nasal epithelial cells, and in one dish we added pneumococcus 23, and in the other we added probiotic, that is lactobacillus with pneumococcus 23. So for a patient to develop an upper respiratory tract infection, the first process by pneumococcus is called internalization. That is, it has to make a break in the cell membrane and then internalize itself. What we found is that in the Petri dish which had probiotics, it prevented internalization itself. So the chance of patient developing URTI becomes very less. But that was a phase 1 clinical trial. Of course, it's going to take us many years to get approval for patients to wash with probiotics, but definitely that is going to be the future. Now we have so much evidence, even cognitive development is linked to probiotics. So if you give your children, small children, probiotics and flavonoids, that has shown to really boost their cognitive development. If you have observed, now we have lot of cases of autism. At least in India, we have a lot of cases of autism. Why do you think that is happening? So what probiotics our parents or grandparents had, we have probably 10-20% of that diversity. So with each generation, this diversity will keep coming down because of the rampant use of antibiotics. So that is one. If you want to take one point from today's or the whole workshop, it is this: don't hesitate to take a nasal swab and then decide if you want to give antibiotic or not. That sinus infection is not going to kill the patient. Okay, but what you are doing unknowingly is that you are killing all the gut bacteria and making it worse for the patient in the long run. When you take away the balance between TH1 and TH2, okay, so what is TH1, TH2 in the thymus? From the bone marrow, the cells go to the thymus and there they are categorized into two groups. TH1, which is going to fight your infections for you, TH2, which is going to cause allergy and autoimmune conditions. So if you take down all the TH1 cells, then the TH2 is going to increase. That is why we have so many patients with allergies, so many patients with asthma, so many patients with autism. Yes, immunotherapy works, but the problem with immunotherapy is their immune system is set up a certain way for the last 20, 30, 40 years. So to change that, immunotherapy will take at least 3 to 5 years. And the long-standing effects of immunotherapy we don't know. The reason being that compliance is a problem here. Okay, so what happens in immunotherapy is whatever the patient is allergic to, dust, pollen or whatever, you give the same thing in a lower dose and very slowly you increase the dose.
Thank you, Dr. Golab. Though we are using antibiotic and anti-state and montelukast regularly, including our pharmacist, but this is the time to think the side effect of this and to the another. And we actually we are regular, sir.
So that biopsy becomes very important. If the fungus is outside of the mucosa, okay, that could be saprophytic or that could be allergic. There is no role for systemic antifungal because it has not penetrated your sinus. If I take a swab from your sinus also, we will find fungus because it's ubiquitous. You cannot escape fungus. But if the fungus is inside the mucous membrane or if there is angio invasion or neuro invasion, yes, definitely I will give antifungal.
Thank you, sir. We usually practice sometimes turbinectomy, cauterization of the turbinate, and the view of control of allergic rhinitis. There is any role of this?
No, but allergic rhinitis not routinely we are doing, but in case of polyp surgery, during polyp surgery we do if nasal obstruction due to DNS and correct DNS and turbinate is hypertrophy. If we not cauterize turbinoplasty, microdermabrasion, we always prefer. And also one slide don't mention skin prick test and immunotherapy also we are doing routinely in case of allergic polyposis.
You don't practice cautery?
No cautery. Last 15 years and I was not doing cautery.
If the turbinates are hypertrophied and it prevents medication to go inside, in that cases some sort of turbinate reduction may be done, but not the surface cautery. It can be done by submucosal coblation, by coblation probe, or any type of turbinate reduction by submucosal probing, or by, as he has said, by microdegrader. You can reduce the turbinate to make approach for breathing and drug to reach the nasal cavity.
Thank you, sir. There is lots of questions in our question bank, but due to short of time, I have to skip the most of the question. Our last question is, what are the main obstacles to become good endoscopy surgeon in developing countries? This is an interesting question. In developing countries, we have to work at lots of limitation regarding logistic support and operational system for financial consistency. We are working while overcoming this problem, and I'd like to request our sir as a endoscopy surgeon in your country.
There are many
limitation.
Yes, there are many obstacles there. Actually, I have faced some problems, and I can say these things. Number one, instrumental facilities. Number two, training facilities. Number two, posting and transfer of government doctors. And number four, the doctors who are posted in private medical college, they are thinking, the medical college authority thinking about their business sides as well. And everybody is not as potential as like Professor Ashraf. He could manage everything in a private medical college. So even we can give a clap for Professor Ashraf as well. And so these are the things.
What is the logistic support? Well, God, this is the main obstacle.
Yes, I told about the instrumental support or logistic support as well.
This is the main thing.
And even
Training of the trainers and trainees.
training and trainers, yes. Even in government medical colleges, all have, in every medical college there is no dead body morgue facilities. So even in BSMMU, we had for very short time we have a cadaver facilities, maybe 6 months or like that. And Dhaka Medical College, they have huge supply of dead
In our
bodies.
country, the office time is made.
Office time, yes, it should be.
There is no CMA credit for the students, whether they train, but it should be.
व्यसन त डेड बडी भएस व्यसन